Hello, everyone. Thank you again for joining the third session of the Culturally Competent Learning Collaborative, hosted by the National Center for Health and Public Housing. This is the third of 4 sessions on this topic. If you are just joining us for the first time, you should have access to the recording and the slides and handouts for the previous sessions through Moodle. And if you are joining us again, thank you and welcome back. My name is Saki Malik Cho. I am with the National Center for Health and Public Housing. And since this is our third time together, I'm just going to move through some of these background slides. At this point, you've seen them several times. Just a reminder, the National Center for Health and Public Housing is a national training and technical assistance provider. We work with health centers and housing authorities and other stakeholders to increase the access, quality of care, and improve health outcomes for public housing residents. Just some basic housekeeping items. We would like for this to be a very engaging session, and there are many opportunities to interact. We have the chat open, and we are hoping that you use it throughout our time together. Feel free to add an introduction to yourself over the chat. And while you're listening to the content today, please add your thoughts and questions as they come to you so that when we get to the Q&A portion, it'll be ready. And if you have, and if you see a question or a comment, please by all means respond. I will also be asking you questions through the chat periodically, so please go ahead and open that chat box so you're able to view all of the discussion easily. You can also raise your hand if you'd like to make a verbal comment, but please mute yourself and only turn your mic back on when you're speaking. Again, just a reminder of the contents of the welcome packet. You should have received this when you registered for the Learning Collaborative. It has the main goal of this Learning Collaborative, which is to assist health centers in the adoption of the CLAS standards and to help health centers and providers treat the diverse patient population. Again, my name is Saki Malik Cho. I'm the Director of Research, Policy, and Health Promotion at NCHPH. I'm joined by my colleagues, Fide Sandoval, our Research Assistant, and Dr. Jose Leon, our Chief Medical Officer. So together, the three of us will be covering the fundamentals of cultural competency, language access, and community partnerships through a combination of case studies and didactic learning. And we're going to do that over these. We did it for the past 2 sessions, and then another 2 to go. So the welcome packet has the dates and times for all of the sessions, and it also provides some instructions on how to access Moodle. That's where the recordings and the slides and the handouts are, and all of the resources for these sessions. Oh, just briefly, I know we had a little bit of technical issues with the Moodle, but I think those have been worked out. So you should be able to have access to that now. Again, you're able to receive continuing education credits by participating in this learning collaborative. You have to register online and take a pre-test and then a post-test after each session. The information on how to register are in the welcome packet. This is the last session that has CMEs available, so make sure you sign in and do the pre-test and post-test if you're interested in the continuing credits. So just a brief recap of what we talked about last week. Last week we talked about the role of language and patient-provider communication. We talked about the legal and the policy requirements for providing language access services, and we described some of the business practice issues related to providing language access services and the costs of not doing it. We also talked about the components of effective personal intercommunication, the roles of an interpreter, understanding the characteristics and the qualifications for assessing the competency of interpreters. We also talked about the importance of effective language access services with respect to written materials, and then the components of the interview process and the factors that are necessary for providers to effectively work with interpreters. So structuring culturally competent care, this is the last of the sessions that are going to be talking about content. Again, CLAS Standards is an acronym for the National Standards for Culturally and Linguistically Appropriate Services in Healthcare. This is developed by the Office of Minority Health. And today's session is going to be a little bit different from our previous sessions, but because we are kind of switching from the clinical setting to talking about cultural competency overall in the organization. Again, each theme or each session consists of 3 lessons called modules, and I'm going to be providing you with the learning objectives for each of the modules as we move through. So the first one is the importance of environment and climate. So the 3 learning objectives for the first module are listed here. The office environment is a really critical element for providing culturally competent care, because it's not just the responsibility of healthcare personnel and physicians, but also staff. And it's important to understand and assess your organization according to according to the principles of providing culturally competent care. And this will help you develop specific strategies to improve the clinical environment that serves the patients in your community. And that's not to say that your office staff does not treat patients appropriately, but we're just saying that it's everyone's responsibility to recognize situations that can be handled in a more culturally competent manner. So we are going to start with a case study about Gebru Gadada. He is an Ethiopian immigrant who recently experienced a heart attack, and he is coming to the office to get assistance with health education in his community. So Fide, would you mind starting that video, please?
Can everybody see the video? Yeah. Okay, perfect.
I think there's a mistake. Mr. Gadada has been Dr. Rivera's patient, and he's been seeing the cardiologist in Blueville for months.
Yeah, I'm not sure what's going on, but he specifically asked to see you.
Burning in the chest, heaviness and pressure, some pain in the arm, and shortness of breath. And he had a heart attack. He needs a cardiologist. Why me?
Hello, sir. What can I do for you today?
Dr. Johnson, you know that the cardiology team at Bluefield is providing me medical care. That is not why I'm here. I'd like to speak with you, man to man. Here is the thing. While I was in the hospital, I had time to think. And Dr. Rivera was right about everything she said about my heart disease months ago. I wish I had listened to her then, but I felt I was healthy from all the work I did in Ethiopia. Doctor, there's a whole community of people from my country just like me, or just like I was before my heart attack. They smoke, they eat bad food, they never exercise. I wish I could tell them all the things that Dr. Rivera told me before my heart attack. But I do not know how. I need your help. Nobody feels that something like this will happen to them. They think they don't have any control, so they just keep on acting the way I used to act before I went to the hospital. I wish I could change that.
Well, we'd be happy to see any one of them here in the office.
That is part of the problem. My people do not feel welcome here. That is why I come to you. They need to see you. People are not treated well here. They're not made to feel welcome. They feel as if this place has nothing for them here. And many of my people don't speak English well enough yet. There's nothing to help them understand what to do or what people are saying to them. Dr. Johnson, would you come to a meeting with my community and teach them about heart disease? I could translate for you. People very badly need to know about preventing what happened to me.
Mr. Dato was a poor farmer who immigrated from Ethiopia many years ago. I came from a wealthy family and graduated from a prestigious medical school. But, differences aside, I can't ignore a call for help.
Why don't you give me some dates and I'll see what I can do.
We'll work around your schedule. Let me know when you are free.
Okay, thank you so much, Fide. I'm going to turn to Dr. Leon and ask you, Dr. Leon, what are your thoughts about what you just saw?
Thanks, Saki. This is a great video, and there are a few things that I would like to highlight. First is the need that we have in the community to assess the needs in our population. It's very, very needed to have health centers going to the to different partners in the community to check what the needs are, specifically regarding the population that you serve, whether you need health educators, you need to also see what the needs, the healthcare needs are in your population and what preventive services you can offer. From the health center perspective, it's very important to notice that you also need some signage and different things in the health center showing that you offer your services in another language, the need to hire people within the community who are able to speak that language, so people feel that they are welcome to the health, in this case, to the health center. And then the need as a provider to go beyond your role. Sometimes you will be asked to provide some health education and promote health education. So those are the items that we have to consider. And even if you cannot do it as a clinician, you need to have, or you can use your health educators or your promoters or your community healthcare workers to provide these services.
Thank you so much, Dr. Leon. So today we are going to discuss some strategies for assessing community health needs and building capacity to respond to those needs with culturally appropriate community health services. So cultural competency needs to be fully integrated into the daily life and practice of an organization. It needs to be grounded in an organization's identity, how it recruits staff, how it treats patients, how it provides care, and it needs to flow throughout an organization, both from the top down and from the bottom up. So the CLAS Standards 8 and 9 can help an organization integrate aspects of cultural competency into their daily practice. I would say that it's important to be realistic in the goals that you set up and take them one step at a time, assigning responsibilities and establishing clear measures of success. Each health center should perform a baseline cultural competency needs assessment, and that self-assessment should focus on the capacities, the strengths, and the weaknesses of the organization in implementing the CLAS standards. These results should be reviewed and discussed to identify assets, weaknesses, and opportunities, and also used to develop action plans that might include training and interpreter programs. All staff must be trained and educated in various aspects of cultural competency. Because front desk staff are the first point of contact for patients, miscommunications that are encountered there often carry over into the office visit. So as soon as patients enter the office environment, they may encounter attitudes and behaviors that aren't congruent with their perception of respectful healthcare. And those situations may include delays in appointments due to miscommunication, loss of revenue because families don't feel welcome at the front desk, loss of referrals and reputation when families report to other people in their community about their negative experiences at the office, and or a possible filing of grievances or reports of discrimination based on the treatment by clinical staff. So the first bullet here on this slide mentions cultural sensitivity training for all staff. And although there is no standard curriculum for this topic, the Office of Minority Health offers some suggestions about important issues to discuss, including the effects of differences in the cultures of staff and patients during the clinical and other workforce encounters, including the effects of the culture of American medicine and clinical training, the elements of effective communication among staff and patients with different cultures and languages, including how to work with interpreters and telephone services, and strategies and techniques for the resolution of conflicts between staff and patients that might be due to racial or ethnic or cultural conflicts, healthcare organizations, grievance procedures, and how they're handled. Developing cultural competency in an organization is a long-term task with many activities, and developing a strategic plan that can be implemented over several years with interim measurements and evaluations of results can help make that task manageable. Information should be obtained from the Information obtained from the organizational assessment should be analyzed to identify areas for improvement. The information can be used for strategic planning to address weaknesses and develop cultural competency throughout the organization. The purpose of the strategic planning is to help an organization define and structure goals and activities and resources to achieve their objectives. And developing cultural competency and providing culturally and linguistically appropriate services should be included as an integral objective in all healthcare organization strategic plans. And planning should be coupled with evaluation and a continual process to ensure the success to ensure success and improvement. Successful planning also includes other principles such as community input and involvement in the planning and the evaluation process, and ongoing assessment that ensures the continual reevaluation of the results directed towards even further improvement. Although the CLAS standards provide guidance about strategic planning, they don't suggest a connection between compensation and culturally competent care. So in your handouts, you have an office environmental assessment checklist that will help you consider your organization in terms of culturally competent practice. FIDE sent you an email earlier referring you to this handout with some questions. And I just would like to take a moment to reflect on some of the themes that are covered in this checklist. Please take a look at the questions under the materials header. Does your office post signage in languages appropriate to your practice and the community, as Dr. Leon mentioned? Do videos or other media for education and treatment reflect the culture and the ethnic background of your practice? Does anyone have, on this call, have a successful technique for developing patient materials that you would like to share? So I'm going to pause there and see if anyone wants to comment in the chat or raise their hand and speak verbally about anything that they do at their practice for developing patient materials that they would like to share. And while we were waiting to see if anyone wants to share, Dr. Leon, would you mind letting us know what you would suggest for developing patient materials?
The first time I saw this assessment came to to my mind, the 19 program requirements. And I'm quite sure that we have many health centers very familiar with the HRSA's 19 program requirements and the signage and all the other instructions are part of the 19 program requirements. So it's very important to match the needs in the community with the 19 program requirements. So you can offer the health services that your population needs, but at the same time, you are being you also have everything that you need when you have a site visit, and you can provide that you are doing your 19 program requirements as well. The other thing is that sometimes it's very difficult, and I understand this issue that to translate materials, specifically if you are looking for something for a chronic medical condition. And we've been discussing when we had the first and second sessions that sometimes you can go to the federal agencies' websites. CDC provides a lot of fact sheets and materials in several languages that you can use to promote some preventive measures for some patient with some chronic medical conditions, or if they need any other services. You can also go to NIH. NIH has some very good materials translated, specifically if you're looking materials for your patients with diabetes. So those are the strategies if you cannot translate the materials, and also make sure that you contact or you have at least some kind of communication with your state health department. They also provide materials in other languages.
That's a good point. Thank you, Dr. Leon. Okay. Now we're going to move to the second module, and Fide is going to give us the overview for this section.
All right, thank you so much, Saki and Dr. Leon. So in the next section of this presentation, we're going to highlight some approaches to assessing your community. So this module discusses the importance of data collection and analysis and strategies for using and managing data. So through our next poll question, please let us know how many of you are currently collecting some form of data about your community in your practice area. So are you currently collecting demographic data about your community? All right. So 89% said yes and 11% said no. It's very interesting. All right, so to set the stage for discussing community assessment and achieving a greater understanding of health trends and issues in your practice area, we're going to view a case study featuring a 4-year-old named Holly Ivy. Give me 1 second.
She's been to the emergency room 3 times in the past month. Why can't these parents just learn to give their kids the medicine like they're supposed to. I don't envy Mrs. Ivy. She cleans houses for a living. And on a meager salary, she can't afford daycare for her daughter, so she brings her to work. As if having asthma wasn't enough. The poor girl has to tolerate dust, dirt, and all manner of cleaning chemicals on a daily basis. Holly, it looks like you have had some adventures at the hospital since the last time I saw you.
I brought her to work one day and let her play outside. I was cleaning the Walters house. They are big smokers. Her breathing sounded so bad that I brought her right to the emergency room. Then the other time, I had forgotten to bring the medicine they gave us. I brought her to the Walters house again, and she was short of breath, so I brought her back to the emergency room just in case.
Why didn't you bring her to see us after the first emergency room visit?
I had to leave work early, and I didn't get paid. And then the car was broken before that, and I spent all my money fixing it. Without my car, I can't work. We just didn't have the money to come here. We can't pay the emergency room bills either. I just tell them that. It's true.
What was the third emergency room visit?
I was breathing, and it sounded funny. I got really scared, and I couldn't breathe even more.
Has Holly been taking her medicine?
We tried a while, but she still has attacks. You've got to give me something to cure it. I can't stand to see her suffer so much when she tries to breathe.
Mrs. Ivy, Holly needs to take her medicine. I know it takes a while, but you need to make sure that she takes it. And we also need to find out what triggers her asthma, like smoke exposure. And we need to try to manage it that way too. I'll tell you what. Can you come into the office next week? I'm going to explain to you then how to manage Holly's asthma. But in the meantime, you've got to make sure that she takes her medicine. Oh, and Mrs. Ivy, I'll have our staff check into something for you before your next visit. Remind me next week when you come in. There are children's health insurance plans in every state for children without insurance, even if a parent works. And I'm quite sure that Holly would be eligible. Okay.
So Dr. Leon, if you were Holly's doctor, how would you have helped her?
Sorry, I was muted. There are a couple of things here that we have to analyze. First is that as a clinician or someone who is taking care of a patient also needs to consider the social determinants of health affecting your patient. Either the patient is underinsured or has no insurance. That's going to be a big issue, whether your patient, and in this case, is either unemployed or just is working part-time. So those are other things that you have to consider when you are with a patient. It's very important to notice as well that you need to know your community. In this case, our experience with public housing is, for instance, a recent publication, a hot CDC publication, shows that 1/3 of those living in public housing are current smokers. So that's another issue that you need to know. That's the reason why you need to assess the needs in your community and what the issues are. And the other factor in public housing, for instance, is lead exposure. These are usually old buildings, and you need to make sure that you know everything, not only the determinants of health, but the environmental issues affecting the population. I had the opportunity to work with rural and agricultural workers for some years, and they have, or they're more likely to have, kidney conditions, for instance, because they are under the sun for several hours working outside. And those are the things that you need to know as a clinician. My recommendation, and this is my personal recommendation is, if you are new or if you have someone of your staff who is new, it's always a good idea to go see the neighborhood, and learn. It's going to give you a better perspective of the needs of your patients.
Yep. That's correct, Dr. Leon. Thank you so much. So next we're going to talk about why is data collection and analysis important. So collecting data on the use of and access to healthcare helps providers increase their understanding of existing disparities and develop strategies to combat them. These are just a few reasons why collection and analysis are so important. So can you think of any other reasons from the ones that are listed here? You might want to begin with developing a community profile to gain insights on the demographics of the community you serve. In your materials, you have a handout called Data Collection Resources to help get you started, and this will be in handout 3.2. So this information can assist you in developing individual practice profiles and needs assessments for the populations you serve. CLAS Standards 10 and 11 provide direction on data collection and analysis. On the next slide, we will cover these in more detail. So we talked about collecting data to develop a community profile. A needs assessment goes hand in hand with data collection. Needs assessments also include summary profiles of healthcare conditions and needs and identify issues or concerns that require special resources or attention. So for example, individual data about language needs, such as a patient's need for an interpreter, should be available to those who can arrange for interpreter services. Your office should have an intake and registration process that includes the patient's self-identified race and ethnicity, country of origin, and language spoken. And this information should be also integrated into the organization's information management systems. Community members should be involved in designing and implementing data reports, such as community profiles and needs assessments. And community profiles include demographic information such as income levels and employment of the population.
Fede, do you mind if I ask you to pause for just a second? I did see someone with their hand raised, a Mr. Eugene Noor. I am going to unmute your line, and please let me know if you had any comments. You're self-muted. If you can unmute your line, you should be able to talk. There you go.
I'm really sorry. That was done in error. I really apologize.
Oh, no problem. No problem at all. I did see somebody else with their hand raised, Miss Sherry Adams. I'm going to unmute your line. And if you want to unmute and let us know if you had any thoughts or comments. Perhaps that was an error as well. Okay, sorry about that. Fide, go ahead.
No, not a problem. So now we're going to talk about about addressing needs to provide language services, right? So information about language access services is thoroughly covered in theme 2. However, I would like to highlight a few points about organizational assessment in terms of providing oral and written language services. As a reminder, LEP stands for Limited English Proficiency. So it is critical to remember that individuals with limited English proficiency, LEP, are protected by the 2003 Office of Civil Rights Decree, which states that any group who accepts assistance from HHS must take reasonable steps to provide meaningful opportunity for individuals with limited English proficiency to participate in HHS-funded programs. We recommend a 4-factor organizational assessment to determine if your organization is taking the appropriate steps. So the intent of assessing these 4 factors is to offer a balance that ensures meaningful access to critical services for persons with limited English proficiency while not imposing undue burdens on small businesses, local governments, or nonprofit organizations. So it is also important that when we collect data to protect patients' rights, we protect patients' rights to privacy. We can't mention patients' rights to privacy without automatically thinking of HIPAA regulations. So HIPAA was designed to assure that an individual's health information is properly protected while allowing the flow of health information needed to promote high quality healthcare and to protect the public's health and well-being. HIPAA also does not preclude collecting patient data, but does not provide guidance on using the data. So de-identified information is basically information from which common identifiers have been removed. Common identifiers include name, birth date, and social security number. Summary statistics that are developed using only de-identified health information are often very useful to healthcare organizations and do not violate HIPAA requirements also. It is important that your office staff receives training so that they understand privacy procedures and keep patient records secure if they contain identifiable health information. So careful planning can create efficiencies and reduce data collection costs, especially in smaller practice settings. So what data collection procedures have been implemented in your office? Has this been beneficial? And you're also more than welcome to provide your response to that in the chat. And would you recommend it to other practices as well? So other sources for collecting targeted data from individual patients include interviews, surveys, and focus groups. And we have now finished the material for the second module, and we will move on to the last module in this theme of building community partnerships with Dr. Cho.
Okay. Thanks, Fide. Okay, so this module provides information about forming partnerships in the community to assist in developing cultural competency and providing culturally competent care. I have a polling question. Fide, do you mind showing it? I'd like to know how many of you are in practices that are involved in community health partnerships. So Fide, I see you have it up. So the question is, are you involved in community health partnerships? Okay, Fide, can you close that poll? Oh, great, everyone is. Perfect. So the three learning objectives, oh, can you not see my screen? There you go. Okay, so the three objectives for this module are first, to describe the importance of developing health-related partnerships with the community, to identify components of forming community health partnerships, and then list the characteristics of the successful community partnerships, and then to describe the benefits of including minority community members in health partnerships. Community health partnerships are relationships between two or more organizations to achieve common public health goals. Healthcare providers and organizations who work together can achieve common public health goals, and this is particularly important for health centers that are located near public housing to improve care for public housing residents. It's crucial that members of the community fully participate in giving out input to the strategic planning and the community interventions and participate in the community health partnerships. There are many different potential partners in your community. This slide highlights some of the folks that you might want to contact, including other healthcare providers or health organizations, state and local health departments, but also other local, state, and federal agencies, including housing authorities and nonprofit groups. Because each partner organization has its own expectations for the partnership, the partnering really has to benefit each of the member organizations. Partners need to articulate the benefits they hope to achieve for their organization, and they should design the relationship so that each member organization benefits from that partnership. And partners should seek each other seek other partners that have a vested interest in the specific public health problem that's being addressed. The real work of creating partnerships requires not just capitalizing on each other's strengths, but also mitigating weaknesses. For example, keeping the number of partners manageable, assigning tasks to small groups, and streamlining administrative processes. In your materials, you have a handout that lists factors for successful collaborations. It's handout 3.3. But the factors that are outlined for successful partnerships include a shared vision, agreement on the mission goals and outcomes, mutual trust and respect, identified strengths and assets, clear and accessible communication, flexibility, as well as processes that are based on the input of all partners. Partnerships with minority community members can assist providers in developing appropriate services in a more cost and time-effective way. Building community relationships can provide valuable resources for language services or education about chronic diseases and other conditions for non-English speaking patients. Without help from the community, it might be time-consuming for a health center to identify and track demographic and epidemiological information. So we're almost done with this last module. I'd like to just summarize the content we just discussed in this session. Healthcare providers and organizations must work together with the community to achieve shared public health goals, and partnerships include both soliciting input and demonstrating outreach behaviors. A partnership should be structured to meet the needs of individual partners and to achieve the partnership's goals. It's especially important that members of minority communities have full access to provide input and participate in community health partnerships. One opportunity for engaging members of the public housing community is to go to the resident advisory groups or the resident leaders and the tenant groups that are or the program managers at the housing authority. All of those are different avenues to get public resident input into your activities. So we're going to conclude this session by watching another case study where the members of the office make progress towards assessing their service area and reaching out to their community. I hope this case study will provide you with some ideas for ways to approach your community assessment and partnerships in your offices, in your health centers. So Fide, can you please load that one up?
Okay, Linda, why don't you go first?
I've been keeping track of a lot of patient data here in the clinic, and I think we've got some major concerns that need to be addressed. But the problem is, we don't have the time or the money to do what's needed. Now, I just simply looked at every chart that came across my desk for a few data items and kept track, nothing too scientific. But what I discovered is that many kids in this county have never been immunized. And also, a lot of kids, mostly blacks, don't have current immunizations or health insurance, even though they'd be eligible for it for state insurance. And many of them have asthma. Now, I've been trying to train parents about asthma, convince them to get their kids immunized, and get them information on the insurance. But I feel like I never leave the office, and I'm still not making a dent in the problem. I need some help.
I've got the same problem. Mr. Dato wants someone to help teach the Ethiopian community about heart attack risk factors and healthy living. There's no doubt they need it, but I just don't know where to find the time. I've been doing some research myself. Our Ethiopian population has significant percentages of untreated high blood pressure, very high cholesterol, and obesity. Apparently, they believe that the heart regulates the body through heat, and they don't need to be too concerned about anything relating to blood.
Okay, then. What are you suggesting?
Well, I was wondering if we could do some research into patient education. Maybe talk to the health department or the community college in Blueville to see if anybody could help us. If we could get an asthma education program together, maybe we could teach some classes or train others in the community to mentor others in managing their kids' asthma.
Exactly. What about talking to a foundation? Or maybe we could get a student intern to help by determining where we should target our efforts.
Sounds like it might cost some big bucks.
Yes, but if you consider all the time that we spend on explaining the same thing over and over, I think it would benefit us in the long run if we did some patient education now. Plus, I bet there are some great materials that are available to us for little or no cost. We just have to find them.
You know, the hospital might be interested in helping too. They'd probably love to get parents to manage their kids' asthma, and they'd certainly love some help in getting the kids insured.
There's one more thing about cost. I think we're losing patients. I know for sure we're losing a large Ethiopian patient population because we can't provide them with the services that they need. It's a simple problem on the surface. They just need basic training in proper diet, exercise, and heart health. But the problem is, it has to be in their language.
All right. Well, since you seem so enthusiastic about this, I think we should take a day away from the office to come up with a good strategic plan for dealing with this. I mean, if we're going to do this, let's do it right.
All right. Let me write some of this down. All right. First of all, I think we need to get some community leaders into the office and to see if they can't get the minority communities to.
Okay, can you see my screen? Okay, hold on. Okay, so I just want to add to what the conversation that the folks were having around the round table. We've talked a lot about members of racial and ethnic minority groups, but another strong culture, at least in our health centers, is the public housing community and the public housing culture. And another important level of information to gather is whether or not your patient is a public housing resident, and what the housing status is for your patients, and looking at that segment of your population for prevalence of disease and chronic conditions, and seeing what issues are most challenging for those public housing residents, patients in your community. I'm going to pause for a second and ask Dr. Leon his thoughts about what we just heard in the case study, and then go to Q&A. Go ahead, Dr. Leon.
Thank you, Dr. Shaw. This video reminds me a recent activity that we hosted. We had a national conference, and we were talking about community partnerships. And you were mentioning, Dr. Shaw, about the need to go to different organizations. In this case, if you are a public housing primary care grantee, probably you will have to go to the public housing agency or agencies or any other organizations that can help you with the services that you provide. This one in particular was very interesting because the community health center was trying to put together a health promotion program on prostate cancer, and they wanted to screen some patients, and there were no place where they could do it, so they contacted the barbershop, and through everybody goes there, and everybody had their hair done and all that stuff. So they basically were providing to the appropriate population the health promotion and the education at the barbershop. So you need to be creative. You need to go, in addition to all the agencies that you work with, you need to see where they get together, where they congregate. And that's the reason why I said in the very beginning that if you are not familiar with the neighborhood, go to the neighborhood, look at where people go and congregate, and you will find good ideas, and so you can promote any of either your health promotion activities or anything else that you have in mind. Just as a reminder as well, Dr. Cho has been is working right now on updating a toolkit on community partnerships. That one is going to be probably ready by the end of, probably by early spring. So that's something that you will be able to find on our website. That is going to give you ideas on how to establish additional partnerships in the community.
Great, thank you, Dr. Leon. Does anybody else have any questions that they'd like to share? You can do that either through the chat function or raising your hand. If not, I would like to thank you all for your attention and participation in all of the sessions that we've had so far. Again, if you need to get CME credits, you can go to the Think Cultural Health website and obtain them there. We will be sending an evaluation survey shortly after this. It's very helpful for us to understand ways we can improve our sessions. And our next session, which will occur on December 1st, is really an office hours. We're really hoping that this is an opportunity for you all to communicate with each other and share your best practices and challenges, and we can discuss some potential solutions for any challenges that you face. We will be inviting a health center to kind of talk through their efforts to improve cultural competency at their health center. So it would be nice, I think, to have that health center perspective or real life perspective sharing, and we would like to invite you all too to describe some of the things that you're doing in your health centers. Dr. Leon or Fide, do you have anything else that you'd like to add?
Not at the moment.
The other community partnership, and I know the health centers are working on this, but it is not mentioned, is the need to go to churches. Again, those are where your patients congregate, where the patients talk to each other, where you will find a lot of information about the health status of your patients. So if you have CHWs or health educators, that's another good place to go in the community.
Great, that's a good inclusion. Anything else, Dr. Leon, before we wish everyone a happy Thanksgiving, and we'll see them after the break for the last session?
No, just to remind the audience to have a happy Thanksgiving, a safe Thanksgiving, and follow the preventive measures next week as well.
Right. Thank you so much. Goodbye.
Thank you. Bye.